I thought that I would come and tell you a little bit about Canada, and in particular, a little bit about the province of Saskatchewan, in which Medicare, which is what they call their healthcare system, was founded. And it was my privilege, having been there so long ago in the mid-70s, to meet and work with some of the people who had been involved in getting Medicare started in the province. And the way they did it was, in fact, one province at a time. And the first province was the province of Saskatchewan. And the reason that it started in the province of Saskatchewan was that they had a visionary leader named Tommy Douglas. You can Google him. You guys have a governor in John Corzine who, while he doesn't have the same background as Tommy Douglas, does have a deep commitment to health care for all and has proposed that a single-payer solution is the appropriate solution. And they found that the doctors were somewhat better trained. And why did they find practicing in Saskatchewan attractive? Because the bills get paid. When you have a health insurance system, the bills get paid. You don't wind up chasing after bad debt. Doctors came over during the doctors' strike in '62 from the UK. And some of them settled there. Some came just to help out during this transition period, and many of them stayed. And what they said when they talked to the Canadian docs, the Saskatchewan docs in '62 was, you know, you guys really ought to go for this, because what we found out is we can be doctors. We don't have to be bill collectors. We make more money because we're not chasing after bad debts. I mean, it's, you know, it's simple stuff, but it gets so obscured by the powers who are making out like bandits. And it was ever thus. So, centralized authority cumbersome? No, not according to these authors. But per capita in Canada in 1999, about $300 in administration, in administrative costs, versus in the U.S. in that same year, about $1,050. Okay, doctors' attitudes toward the system were overwhelmingly positive 5 years later when this book was written. A survey was done, despite the fact that the Saskatchewan Medical Association cautioned the doctors not to reply to the survey. Many of them did, and of those, an overwhelming majority, 72%, said that they were satisfied with the new system. So that's sort of how Saskatchewan got the ball rolling, and then that was 1962. Province after province followed the model, so that by 1971, Canada, every province and territory in Canada had a similar program. Then what happened in 1983 was the passage of the Canada Health Act, which guaranteed a certain set of principles and was really brought in to defend the concept of a single tier of care. There has been, since before the system ever started, a steady drumbeat saying, well, shouldn't wealthy people who can afford to pay privately for care be able to buy care on their own? And the answer in Canada has been no. That if you're in the system and you're getting care that is covered by the system, let me rephrase that a doctor practicing in the system, providing care that's covered in the system, cannot also provide that care privately outside the system. He or she can provide care that isn't included. You want a Botox shot, you can be sure Medicare is not covering it, and a plastic and reconstructive surgeon will be pleased to do that for you privately, that kind of thing. This is the Canada Health Act of 1983. It's 13 pages long. You see how wide the margins are? Left-hand side is English, right-hand side is French. I want you to think about the Clinton healthcare program that came in at 1,350 pages. And this is the important piece that you have to understand. There are 10 provinces and 3 territories in Canada, and each one has its own healthcare system. So when you hear even a person like myself come in and say, and I stopped myself a few minutes ago, come in and say, the Canadian healthcare system, that's not correct, because there isn't a Canadian healthcare system. What the feds did, remember the provinces and territories are more autonomous even than our states. What the feds did in this legislation was to establish a set of guidelines, and they're very clear guidelines about how each of the systems has to function. But beyond that, you're able to do what you want, and what's maybe more appropriate for British Columbia may not be as appropriate for New Brunswick, not New Jersey, you understood, right. But they don't spell out that you must cover this procedure and that procedure and so forth. What they say is that the system must be universal, by which they mean everybody's in. And that means every resident, just to make that clear. That it must be comprehensive, by which they mean everything medically necessary. And that's the sticky point, because what was medically necessary 40 years ago is not the same thing as what's medically necessary now, and I'll talk about that in a few minutes. Portable. I can take myself and my Medicare number from my province to any other province in the nation and get cared for with no waiting periods, no financial barriers, and so forth. If you've got something really, really complex, you may need to go to Ontario or to British Columbia or to someplace. You know how it is when it's sort of the one person who knows whatever it is you've got. You can go anywhere you want and be treated by anybody you would like to have treat you, assuming that they take you, right? I mean, that's always the case. I find that in New York. Call up some of the specialists. Yeah. Oh, absolutely. And I've had friends who have done that from time to time as needed. So it's universal, it's comprehensive, it's portable, it's accessible, which is a financial issue. That is no financial barriers, but also in a country that has a huge land mass, and a lot of it is very remote. They're talking about the need for every province or territory to make care available to people in quite remote situations. As you can imagine, when we're flying in a nurse practitioner once a week to a community that doesn't have roads, it's not the same level of care and complex care. You know, people get flown out to go to more urban centers to get more complex care. Of course, of course. So sometimes we hear stories about, oh, the Canadians in East Jabib couldn't get whatever it was. Well, of course not, because we couldn't have gotten that service in East Jabib in the United States either. And the final requirement is that the program be publicly administered. That is, that the provincial government set up an authority that does the administration, and that those books are publicly available. That information is publicly available. So that's it, 5 principles: universal, comprehensive, portable, accessible, publicly administered. Those are the bottom line, and there's more about them spelled out in the Canada Health Act.